Hello my dear friends, today's lecture is about acute respiratory viral infections. So acute respiratory viral infections or ARVI include influenza virus, parainfluenza, adenovirus, respiratory syncytial virus, coronaviruses, as well as some other viruses like rhinovirus, as well as measles, metapneumonia virus, enterovirus, herpes virus, Epstein-Barr virus, cytomegalovirus, and many other viruses. But we are going to discuss about most important of them. And what about the common features of all the acute respiratory viral infections? These are the common disorders with variable etiology. That could be the RNA or DNA contained viruses with the potential of epidemic or even pandemic spreading. All those viruses have tropism to respiratory epithelium of different localization. That could be the nasopharynx, larynx, trachea, bronchi, bronchioles, or alveolocytes, means damaging the parenchyma of the lungs. As usual, course of those infections are mild, but could be also the moderate or even severe course. As usual, as I told you before, so most common is mild to moderate and self-limiting disorders. Then severe the course, then lower respiratory tracts are affected. Morphologically, features are generally non-specific with predominant acute exudative inflammatory reactions with hemorrhagic and even necrotizing components in severe course, of course. Severe respiratory viral infections are often associated with acute respiratory distress syndrome, also known as ARDS, and diffuse alveolar damage, also known as DAD. Also, viral infections could be associated with secondary bacterial infection that happen due to the vasoparalytic or immunosuppression effects, as well as due to the direct epithelial damage. So let's discuss initially, before we'll talk about the particular viruses, about those common features. And let's start from one of the most severe manifestations, which is acute respiratory distress syndrome. Acute respiratory distress syndrome is a non-specific type of respiratory failure characterized by the rapid onset of the widespread inflammation in the lung. And as you can see on this chest X-ray image, and that's typical for acute respiratory distress syndrome, lungs are damaged bilaterally and damage is diffuse. Generally, causes can be both direct, which is bacterial or viral pneumonias, aspiration, chest trauma, etc., or indirect, like sepsis, shock conditions, or even acute pancreatitis, and some other indirect causes. Generally, acute respiratory distress syndrome has very specific clinical manifestations, mainly related to respiratory failure. Also, radiological manifestations, which can be seen on X-ray images or computer tomography or MRI, so on, as well as morphological manifestations, and about those morphological manifestations we are going to talk. Exactly, if we are talking about the morphological manifestations, the most common histopathological changes, which can be seen in acute respiratory distress syndrome, is diffuse alveolar damage, or DAD. Is a histopathology term used to describe changes that occur to the structure of the lungs during injury or disease. And most often, DAD is described in association with early stages of acute respiratory distress syndrome. And on this small microphotograph, picture of diffuse alveolar damage is presented. On this schematic diagram, on the left side, there is the normal alveolus and the normal interaction in between the blood and the alveolus and the air inside. While on the right side, that's the typical schematic manifestations of the diffuse alveolar damage. So that is the injured alveolus during the acute phase of DAD, or acute respiratory distress syndrome. What's happened? Due to the pathogen, due to the different factors which cause the acute damage, the permeability of the blood capillaries is increased severely, and we may have widened and edematous interstitial space. As a result of increased permeability, there is active migration of neutrophils, macrophages, lymphocytes, plasma cells into the interstitium and then into the alveolar spaces. Along with the fluid, there is exudation of proteinous substances, including fibrinogen, which then converted into the fibrin. Activated neutrophils and macrophages release a lot of pro-inflammatory cytokines, such as tumor necrosis factor, interleukins, and so on, resulting in secondary alteration and much more pronounced increase of vascular permeability, finally leading to degenerations and necrosis of alveolar sites of first and the second type, some disturbances in surfactant system, so surfactant becomes inactivated, and finally one of the hallmark of diffuse alveolar damage, that's the formation of hyaline membranes, which are composed of proteinous substances. So taken all together, those changes, of course, they will affect the gas exchange in those edematous and inflamed alveolus, leading to severe respiratory failure. So that's the common information, just very short and brief overview of diffuse alveolar damage and what will happen in this case. And later, as you will see, most of the viral infections, most of the severe course of those infections will be manifested with acute respiratory distress syndrome, including the diffuse alveolar damage. Diffuse alveolar damage has stages, and those stages can be divided into three, which is exudative phase from the 1st to 7th day, then the proliferative or organizing phase from the 1st to 3rd week, and finally fibrotic phase, if any, after 3 weeks. Most of cases, of course, we are talking about the acute inflammatory disorders. Histologically, we may see the onset of the diffuse alveolar damage, which is exudative phase. Sometimes, due to the a little bit prolonged course of those infections, we may see proliferative phase as well. Fibrotic phase at all may not happen, or if it will happen, most probably we are talking about complications of the diffuse alveolar damage and some persistent fibrotic changes in the pulmonary parenchyma. And that's the histological image of the diffuse alveolar damage. On this slide you can see the portion of the lung tissue with a lot of alveoli here. As you can see, most of alveoli are filled with some edematous fluid with a lot of inflammatory cells. And we need to point out that this edematous fluid is highly eosinophilic and is mostly accumulated on the walls of the alveoli. So that's the formation of hyaline membranes. And that's the hallmark of the diffuse alveolar damage and finally of the acute respiratory distress syndrome, which is associated with a very severe respiratory malfunction. So let's talk about the first and the most important infection, which is influenza virus. Influenza virus is aortomyxoviridae virus, which is RNA-contained virus surrounded by the lipid envelope. We have generally three types, which is type A, type B, and type C. Envelope contains the viral hemagglutinin and neuraminidase. And exactly for type A, there are around 16 recognized subtypes of hemagglutinin and around 9 subtypes of neuraminidase. And naming of these viruses comes from those subtypes of the hemagglutinin and neuraminidase, like H1N1, for example. Especially type B is also common, but is common as a seasonal influenza. And finally, type C is uncommon type. What about epidemiology? Influenza virus is one of the most common acute respiratory viral infections worldwide. It affects from 5 to 20% of population every year. And exactly type A causes more severe disease and is the major cause of epidemics and pandemics. It may also infect the animals like swine influenza or avian influenza, and one subtype predominates at any given time. And according to the statistics, influenza, and especially type A influenza, is the most common cause of viral pneumonias. According to the course, influenza viruses may cause mild, moderate, or severe disease. And the last one, severe, could be uncomplicated or complicated. Incubation period ranges from 1 to 4 days, and influenza virus has the tropism to epithelium of larynx and trachea, but later may affect bronchi and the lung parenchymal wall. Severe course is associated with viral pneumonia with the features of acute respiratory distress syndrome and diffuse alveolar damage, as well as damage of some extra respiratory organs. We'll talk about this later. As you can see on this diagram, and that is the illustration of the time from 1918 to modern times, and there is significant outbreaks of influenza during this timeline. As you can see here, we have the antigenic drift and antigenic shift. So exactly those outbreaks are closely related to the antigenic drift, means some recombination of human influenza virus with some animal influenza virus with appearance of some extra features, which makes the new virus much more pathogenic, much more widespreading. And below, that's the table with the most important epidemic or even pandemic outbreaks of influenza virus. That is Asiatic Russian flu, and likely is H3N8 or H2N2, and around 300 to 900 million people were affected and around 1 million died. Then the most significant, according to the mortality rate, was the Spanish flu in the beginning of the 20th century, and that is the H1N1 subtype of the influenza virus. Of course, we are talking about the influenza virus type A, and around 500 to 1,000 million people, means billion people, were affected, and around 100, according to the some estimates, so around 100 of people died because of Spanish flu. Then that was the Asian flu, Hong Kong flu, and in the modern time that it was swine flu, with of course much less mortality rate. So as I told you before, influenza virus causes respiratory infections with a mild, moderate, or severe course. So the mild course of influenza is characterized mainly by the damage to the mucous membrane of the upper respiratory tract with acute catarrhal rhinolaryngobronchitis, means affecting the nasal cavity, the nasopharynx, larynx, trachea, and sometimes bronchi. So with the main location is the larynx and the trachea. The gross changes are non-specific. The mucous membrane becomes swollen, hyperemic with excess serous mucus discharge. Here you need to remember that inflammation in mild course of influenza is catarrhal, means that is the mild type of inflammation which is associated with excessive secretion of mucus and leakage of the mucus from the surface of the mucous membranes. Microscopically, we can see inflammatory hyperemia, edema, and of course some lymphocytic and plasmacytic infiltration of the subepithelial layer with hydropic degeneration of ciliated epithelial cells. The secretory activity of the goblet cells and serous mucous glands is increased, again due to the catarrhal type of inflammation. In case of the moderate course of influenza, we may see damage to the mucous membrane of the upper respiratory tract along with the bronchi, bronchioles, and even the lung parenchyma, causing the viral pneumonia with serous hemorrhagic type of inflammation. So gross changes are non-specific, and there are features of serous hemorrhagic inflammation. Microscopically, same, we may see inflammatory hyperemia, edema, and lymphocytic and plasmacytic infiltration, along with necrotic changes in epithelium and now serious hemorrhagic exudate in bronchi, bronchioles, and alveoli. Finally, severe course of influenza could be both uncomplicated with severe intoxication and some systemic manifestations, and complicated due to the secondary bacterial infection. You need to remember that generally that's common information for all the acute respiratory viral infections, that severe course of viral infections could be easily complicated with a bacterial infection, with a shift of the type of inflammation. Of course, viruses cannot cause the purulent inflammation, while the bacteria is leading to, as usual, purulent type of inflammation. So primarily, lungs are damaged with multiple foci of serious hemorrhagic inflammation and areas of atelectasis, emphysema, and hemorrhages. Clinically, acute respiratory distress syndrome is common with histopathological diffuse alveolar damage changes. Grossly, lungs are heavy, edematous with hemorrhagic foci, and such lungs are known as large flu mottled lungs. Microscopically, this is the pronounced serious hemorrhagic inflammation, or in case of secondary bacterial infection, as I told you before, there's the purulent component with severe necrotic changes in bronchioles and the alveoli. And here on this gross patient, you may see the part of the lung tissue which is representative of the large flu mottled lung. As you can see here, the surface of the lung tissue is reddish in color with some foamy, maybe fluid, with some yellowish patches, dark red patches, pinkish areas, and so on, representing the different processes happens in lung parenchyma. These are the hemorrhages, some airless areas, some foci of emphysema, so on. That's the histological slide, and on this microscopical picture we may see the part of the mucous membrane of the trachea. Really, that was the fatal case of influenza virus type B in a child, and you can see that the mucous membrane of the trachea is damaged. You may see also the very pronounced lymphocytic and plasmacytic with macrophages infiltration here, some focal areas of hemorrhages, and significantly edematous and full-blooded vessels due to the inflammatory hyperemia. So that's the appearance of influenza tracheitis, in this case with some necrotic and hemorrhagic changes. Similar changes, in this case, can be observed in the wall of the bronchus as well. We may see the damaged and necrotic epithelium layer. So the epithelium is damaged and desquamated. And the submucous layer, that's the area of hemorrhages with lymphocytic and plasmacytic infiltration. And again, inflammatory hyperemia, full-blooded vessels, and a lot of RBCs in the tissues indicating on hemorrhagic type of inflammation. Finally, in the lungs, that's the viral influenza pneumonia. And on this microslide, you may see the part of the lung tissue with a lot of RBCs inside the alveoli. Means alveoli are filled with exudate, and that is highly eosinophilic exudate up to the formation of hyaline membranes within the alveoli. So all the lumen of alveoli filled with these highly proteinous substances with a lot of RBCs inside. And such microscopical picture, along with the damaged alveolar site, is representative for acute respiratory distress syndrome and diffuse alveolar damage with hemorrhagic type of inflammation, which is typical for severe influenza infection. That's another case on the highest magnification, some part of the alveolus, and again that is influenza infection, but What's different? Again, we may see exudate with a lot of RBCs there, but let's take a look on these cells. Mostly these cells are neutrophils now, and when we see those neutrophils, we need to talk about purulent type of inflammation. But as we know, viruses cannot cause the purulent inflammation. So what must happen in this case? In this case, that's the illustration of severe course of influenza infection, but complicated course of influenza infection. Complicated viral pneumonia. Exactly in this case, that is the community-acquired methicillin-resistant staphylococcus infection, which is really deadly infection. If we see the purulent type of inflammation, it means that viral infection was complicated with some secondary bacterial infection. As we told before, in influenza, especially in severe case of influenza, we may see some extrapulmonary damages. So what kind of damages can be seen? These are the degenerations of tubular epithelium and renal acute tubular necrosis, which is necrotic nephrosis. Also, degeneration of hepatocytes up to the central lobular necrosis of the liver. Different types of myocarditis and toxic damage of cardiomyocytes means myocarditis. Hemorrhagic necrosis of the adrenal glands. Brain edema, focal cerebral hemorrhages, serous meningitis, and encephalitis, as well as thrombophlebitis and thromboarteritis with the formation of thrombi, as well as some other extrapulmonary manifestations. As an illustration of this, that's the gross pavement of the brain hemispheres, and in subcortical areas of the white matter, you may see the focal dot-like hemorrhages in the brain matter, which was related to vasoparalytic effect of the influenza virus and some systemic manifestations of the severe influenza infection. Same in the kidneys. That's the appearance of shock kidney with a pale cortex and the full-blooded dark red medulla pyramids here, and that's the appearance of the shock kidney. And microscopically, in this case, we are going to see the acute tubular necrosis or necrotic nephrosis. One more example of extrapulmonary damage in severe influenza is the damage of the cardiomyocytes, and in this case, on this histological slide, we may see here and probably here the focal damage of cardiomyocytes due to the toxic damages, due to the microthrombi, due to the disturbances of microcirculation in the myocardium. What about complications and possible outcomes? Generally, influenza is rarely fatal in immunocompetent host, and as usual, recovery is complete. In addition to children less than 5 years of age and the elderly, patients with certain pre-existing conditions including asthma, cardiovascular diseases, some seizure disorders, malignancies, diabetes mellitus, or pregnancy are at great risk for severe illness. And exactly death in influenza occurs from intoxication, hemorrhage to some vital centers in the brain due to the pulmonary complications, cardiac or mixed cardiac pulmonary failure. The next infection we are going to talk about is very close to the previous one and is known as a para-influenza infection. So, para-influenza virus. This virus is Paramyxoviridae family and is also the RNA-containing enveloped virus containing hemagglutinin neuraminidase. And up to today's moment, there are 4 types: type 1, type 2, 3, and 4. Generally, the name para-influenza virus. Para means near and influenza means flu. So this virus, according to the clinical and the morphological manifestation, is quite similar to the influenza virus. Para-influenza virus remain the second to third main cause of hospitalization in people suffering from respiratory illnesses. The highest incidence can be seen in young children and immunocompromised patients. Course could be mild to moderate or severe. Incubation period lasts from 1 to 7 days, and this parainfluenza virus infection usually manifests as an upper respiratory illness, like a common cold, sore throat, and croup. Less commonly, it can be present as a lower respiratory infection, like pneumonia, bronchitis, or bronchiolitis. And especially that's typical for parainfluenza virus type 3 and among the elderly and immunosuppressed patients. Morphologically, in case of mild to moderate course, catarrhal laryngotracheal bronchitis can be seen. In severe course, there is interstitial serous hemorrhagic pneumonia associated with acute respiratory distress syndrome and diffuse alveolar damage, same like for influenza virus. As we much more in details discuss about the influenza virus, for this case of parainfluenza virus, we'll talk a little bit shorter. And that's the histological slide of the parainfluenza virus pneumonia. You may see the lung parenchyma with the alveoli. These alveoli are filled with exudate, and this exudate shows the hemorrhagic character, so a lot of RBCs are there. Also in the low magnification we may see few bronchioles with a severe necrotic changes in the bronchioles, and with a high magnification, one of the specific features of the parainfluenza virus is the formation of the giant multinucleated cells with a specific intracytoplasmic inclusions looking like this. Slightly eosinophilic, rounded, surrounded with some transparent halo inclusions. That's the typical for parainfluenza virus infection. With the rest, all the features of the parainfluenza virus infection, especially viral pneumonia, looks very similar to viral pneumonias caused by the influenza virus, with the same hemorrhagic character, serous hemorrhagic character, with a formation of acute respiratory distress syndrome, with a manifestation of diffuse alveolar damage, with the formation of hyaline membranes, and progressing respiratory failure. That's the common feature for the severe courses of those viral pneumonias. One more virus we are going to talk about, that is respiratory syncytial virus. So the respiratory syncytial virus, that is also paramyxoviridis virus and RNA-containing envelope virus with mainly two subtypes, subtype 1 and subtype 2. Respiratory syncytial virus is a leading cause of lower respiratory tract infection in infants and young children. Similar to the influenza and parainfluenza, we have mild to moderate or severe course of this infection. Incubation period varies from 1 to 7 days, and virus affects primarily epithelium of small bronchi or bronchioles and directly alveolocytes. In severe case, similar to influenza and parainfluenza virus, it results in acute respiratory distress syndrome with the DAD. Morphologically, the major histopathological changes are necrotizing bronchiolitis and interstitial pneumonia. Mixed inflammatory cell infiltrates are located mostly around the wall of the small and medium-sized bronchioles. Also, some large multinucleated cells with intracytoplasmic inclusions can be seen. On this histological image of the lung parenchyma, we may see alveoli, some hemodynamic inflammatory changes are there, and in the center that is the lumen of the small bronchiole with prominent necrotic changes of the epithelium, surrounded with a prominent and huge inflammatory infiltration consisting of lymphocytes and plasma cells mostly. On a high magnification, here as well we may see infiltration of lymphocytes, plasma cells, and macrophages, and again with a very prominent hemorrhagic component, which is again typical for the severe course of the viral pneumonias and for respiratory syncytial virus as well. We may see such type of inflammation with a lot of RBCs inside the alveoli and within the interstitial space. What about the multinucleated cells and how do they look like? Generally, those multinucleated cells also can be seen in parainfluenza infection, and that is the respiratory syncytial infection and formation of the multinucleated cells with a lot of nuclei. That is the reaction of proliferative reaction of the epithelium of the bronchi and alveolocytes with the formation of such multinucleated cells. Formation of multinucleated cells can be seen both in parainfluenza and respiratory syncytial virus infection, but in respiratory syncytial virus infection is much more common. And finally, also we may see intracytoplasmic inclusions, and is presented here, that is homogeneous eosinophilic mass looking like this, and it's quite different from those intracytoplasmic inclusions which can be seen in parainfluenza virus. So that could be one of the differential diagnostic feature in between the respiratory syncytial infection and parainfluenza virus infection. One more infection we need to talk about, that is adenoviral infection. Adenovirus, it belongs to Adenoviridae family and is double-stranded DNA virus with capsid. Especially all other viruses we discussed before, they were RNA viruses, while the adenovirus, you need to remember, that is the DNA virus. And for now, totally more than 50 serotypes are described. Mainly, adenovirus affects infants and children as well as immunocompromised patients, around 5 to 10% of all the pneumonias. Due to the specific manifestation, due to the specific localization, adenoviral infection, also known as a pharyngoconjunctival fever, mean affecting pharynx and conjunctiva. According to the course, it also can be divided into the mild to moderate and severe. Incubation period ranges from 1 to 7 days, and acute respiratory disease of the upper respiratory tract is manifested by rhinolaryngomalacia bronchitis, as well as, and probably that will be the main manifestations, these are the pharyngitis, lymphadenitis, regional lymphadenitis, and conjunctivitis. In severe cases, adenovirus pneumonia may be present, or quite often other clinical presentations may include damage of GIT, may include damage of the heart with a myocarditis, damage of the liver, damage of the brain and the meninges, damage of the kidneys, and so on. So there's a lot of systemic manifestations or extra-respiratory manifestations of adenoviral infection. So in case of the mild to moderate course, if we're talking about the morphological changes, we may see mostly catral and the serous type of inflammation. In severe course, is the hemorrhagic component with the necrotic changes up to acute respiratory distress syndrome with the diffuse alveolar damage. And that's the typical appearance of the adenoviral keratoconjunctivitis with inflammatory hyperemia of the conjunctiva. Same inflammatory changes due to the invasion and replication of virus in the epithelium layer can be seen in the pharynx. In most cases, these two symptoms, damage of conjunctiva, affecting of conjunctiva, and affecting of pharynx with the pharyngitis, these are the most common manifestations of adenoviral infection, and especially it affects children. Other cases, or severe cases, adenoviral infection may affect respiratory system, and of course it may affect lungs. So what can be seen in lungs? And generally, those changes which can be seen in lung parenchyma, they look quite similar to other viral pneumonias, with a infiltration of lung parenchyma with the macrophages and lymphocytes. With hemorrhagic type of inflammation, you may see alveoli, but those alveoli are filled with a hemorrhagic exudate here. And on high magnification, one of the specific symptoms of adenoviral infection, and exactly this symptom can be seen not only in lungs but in all the affected organs, which is distinct feature of invasion of adenovirus into the nucleus of the affected cells. That is the intranuclear inclusions, like here or like here or like here, but most prominent it can be seen here. That is the basophilic inclusion inside the nucleus of the affected cells. As I told you before, these changes for adenoviral intranuclear inclusions can be seen in affected cells of the lungs, in the hepatocytes, in the epithelium of the renal tubules, so on. Finally, according to the most important infections, and considering the today's situation, we need to discuss about one very important family of the viruses, which are coronaviruses. So what about the coronaviruses? These are the Coronaviridae family, which are RNA enveloped viruses of mammals and birds, including human. And as for now, there are alpha, beta, gamma, and delta types, with the most important beta viruses. And later, of course, we'll talk a little bit about these viruses like SARS, MERS, and SARS coronavirus 2 or COVID-19. These coronaviruses are important human and animal pathogens, and during the epidemics, they are the cause of up to 1/3 of community-acquired upper respiratory tract infections in adults, and probably also play a role in severe respiratory infections in both children and adults. According to the course, as usual, as we told before for all other viral infections, course could be mild to moderate with a primary damage of the upper respiratory tract and severe with a primary damage of the lungs. And depending on type and course, those infections may cause both upper and lower respiratory tract infection. Also, some systemic changes can be seen, and about this we'll talk a little bit later. According to the morphology, mild to moderate course results in catral and serous type of inflammation, and in severe course, mostly we will see acute respiratory distress syndrome with a diffuse alveolar damage. Exactly, the pulmonary changes are the most significant due to clinical and radiological manifestations, for they are non-specific. What about the coronaviruses and their origin? So that is the large family of viruses, but really coronaviruses are viruses of the animals. Primarily, if we are talking about the beta subfamily or beta type of coronaviruses, the main host for those coronaviruses are bats. Some of them are rats or mice. And then we need the intermediate host, which could be the camels or pigs or cows or some other unidentified animals, and then transmitted to the human beings. That's the origin of the coronaviruses. You need to understand that nature reservoir of coronaviruses are animals. But then again, such like in influenza virus infection, due to the antigenic drift, the animal virus becomes pathogenic for human beings. And that's the problem for coronaviruses, really, and for some other viruses as well. Whereas we may be able to fight against the epidemic sources or epidemic or pandemic sources of infection or foci of infection, and trying to eliminate all the viruses among the human population. But generally, we cannot control the animal population, and we cannot control the prevalence and incidence of the viral infections among animals, especially among the wild animals. And that's the greatest problem for now, and I think for our nearest future. So out of many coronaviruses, during the last 10 years, there were few outbreaks of these infections, and that is the severe acute respiratory syndrome, which is SARS. It was originated from China, with total amount infected around 8,000 people, and around 700 people die. Then the MERS, or Middle East Respiratory Syndrome, which is also associated with the coronavirus infection, originated in Saudi Arabia, with around 2,500 people infected and around 800 people die. And now that is the, again, severe acute respiratory syndrome 2, which is quite similar to the previous one, SARS and MERS, which is known now as a COVID-19. As you know, it was originated in China, and up to the 4th of May, now is more than 3.5 million people infected and more than 250,000 people die. And as you can see here, everything is similar to other coronavirus infection. Origin is a bat. So these viruses are living in bat. Then from bat is transmitted to suspiciable intermediate host, which is camel for the MERS, which is some wild cats for the SARS, and probably to pangolin in case of COVID-19. And then due to the close contact or due to the eating of those animals or close contacts or some unrevealed way, most probably due to eating of pangolin, this virus was transmitted to the final host, means to the human. And after that, this virus become to be able to infect the human, and more, it is able to be transmitted from one human to another human through the respiratory way. So that's the common information about the COVID-19. The median incubation period for now is around 5 days, with the onset of symptoms from 8 to 15 days. And as you can see here, and that's the common statistics in the world, around 81% has the mild course or even the course without the symptoms at all, or just mild cold or mild sore throat, something like this. The 14% with a severe course, means with a viral pneumonias, and just 5% require the critical care, requires the intensive care unit care, and most probably this population is in a significant risk of fatal outcome. And as you can see here, most common symptoms are fever, the cough, some fatigue with less sputum production, decreasing of WBCs, decreasing of amount of lymphocytes, and some other changes. And as you can see here, acute respiratory distress syndrome, according to the some information, is around 30% of cases. On this diagram, we may see very schematic illustration. Of course, a lot of information for now is not very well understandable for COVID-19, but we have generally two kinds of infection, which is the mild infection and severe infection. And of course, so the difference between these two processes is exactly related to response of our immune system, mostly to those viruses, with the formation of cell associates between the macrophages, neutrophils, and antigen presenting cells like dendritic cells, with the releasing of a lot of cytokines, pro-inflammatory cytokines, leading to the vasoconstriction, to some hemodynamic disturbances, activation of the platelets, formation of microthrombi, fibrin meshwork, increasing of microvascular permeability, and then a lot of damage, extrapulmonary damage, whether damage of the heart, damage of the kidneys, damage of the liver, then leading to the multi-organ failure. So as a result, we get the very severe condition which is associated with the damaged coagulation, with the DIC syndrome, with the respiratory failure due to the acute respiratory distress syndrome, with the damaged heart function, with the damaged renal and liver function, and finally the chance of the fatal outcome in this person is increased significantly. And that is the histological slide of the lung tissue with the damaged alveoli in COVID-19. You may see full-blooded congested blood vessels, and now the same. So these changes are non-specific cause, approximately the same picture I've showed you related to influenza virus infection or even parainfluenza virus infection or some other viral infections with the formation of those eosinophilic hyaline membranes and hemorrhagic type of inflammation with the exudation and the formation of lymphocytic and plasmacytic infiltrate here. So that is the morphological picture of the diffuse alveolar damage with the formation of hyaline membranes, which is typical for acute respiratory distress syndrome. So we may conclude that mostly in COVID-19, we may have acute respiratory distress syndrome in the lungs with a diffuse alveolar damage, which is once more time non-specific manifestation of pulmonary damage in viral infections. Some other changes as well as in other infections, exactly, it's quite similar to other coronavirus infections like SARS and MERS, with the formation of some multinucleated syncytial cells as well as a formation of some cytopathic changes and intranuclear inclusions related to the viral particles can be seen here exactly. And those changes could be specific for COVID-19 and coronavirus family infection totally. That's all for acute respiratory viral infection. I wish you to be healthy, stay home, save life, and be engaged in pathology.